I'm Dr. Lei Liu. I'm a fellowship trained bariatric surgeon and general surgeon.
And I'm Peter Jernigan. I'm a general surgeon as well and fellowship trained in bariatric and advanced GI surgery. And we're here today to talk to you a little bit about gastroesophageal reflux disease, or GERD as it's more commonly known. This is a very common disorder. The reason we're talking about it today is because April is Esophageal Cancer Awareness Month, and GERD is a disease that's closely tied to esophageal cancer, and so we wanted to talk a little bit about that. Dr. Liu is going to answer some questions about that today. So the first thing is, what is GERD? I hear this word a lot of people talk about it, and it seems to sometimes mean different things to different people. So what is GERD?
Well, we talked about heartburn, which is actually, technically, if you think about the food you eat in through your mouth, goes to your stomach right here, and the acid in the food actually start refluxing back up to the chest area in the esophagus. That give you a sensation of heartburn, chest pain. That's heartburn. And GERD, which is gastroesophageal reflux disease, is defined as if you have more than 2 times of heartburn per week, which I think actually a lot of people have that. If you have symptoms like that, that's defined as a disease instead of just heartburn. So we talk about how does this happen. If you think of your GI tract as a tube, a water hose, let's say. So things goes in through your mouth, goes through your esophagus, goes to your stomach right here. Now, there's a little valve right here in between esophagus and your stomach. It's called the lower esophageal sphincter. Now, this little thing, what it does, when you eat, food goes through here, it opens up, relax a little bit, so food goes down. But when you're not eating, it closes like this, so it keeps everything underneath in the stomach. It doesn't reflux back up. If you have any dysfunction of that, what we call LES, lower esophageal sphincter, then you start having issues when food's refluxing back up into your chest, give you all this pain, burning, sometimes the acid taste in your mouth, things like that. Now, believe it or not, a lot of people actually suffer from heartburn. About 1/3 of the population in the United States actually suffers from heartburn. And people maybe we don't have to deal with it. It just comes, go, and whatnot. But a lot of people paying attention to it. And nowadays, I have a lot of over-the-counter medication. So people just kind of, going, maybe we'll just leave it alone. We'll see how it does. But actually, there's a lot of things associated with GERD that we need to know about it.
Yeah, so you talked about dysfunction of the lower esophageal sphincter. So how does that happen? What are the risk factors? Who gets that dysfunction? And how do you get GERD?
Well, other than the dysfunction of the sphincter, the number one thing is the food you eat, if you think about it. We talk about people say, I eat pizza, I have a problem. I eat this, I have a problem. Usually, if you're eating spicy food, all the good stuff, Spicy food, tomatoes, onions, garlic, citrus stuff, peppermint, a lot of those food actually will increase the risk of you having a heartburn, which for myself, every time I have tomato soup, I have issues, major heartburn, but everything else I'm okay. So if you know what triggers you, that very likely is a major risk factor for you. Go ahead.
Caffeine, coffee, tea, anything with caffeine and alcohol.
I don't take that, so yes, caffeine is a major issue too, yes. They give you the symptoms of the heartburn. The second thing is called a hiatal hernia. It's more an anatomical thing. So we talked about your GI tract like a tube. It goes here to here into your stomach. There's a muscle right here called diaphragm, kind of separates your chest and your belly. So it has a natural opening like this for your food to go through esophagus to go down. Usually pinch quite tight like this. But if you have any kind of hiatal hernia and stretched out, you stretch out like that, so you lose that control. So if you already lose the control of your lower esophageal sphincter, which is part of the mechanism for it, and you also have a hiatal hernia, that guarantee you're going to have issues with heartburn. There's other things associated with heartburn, of course, like we talked about the food, but also alcohol is a main issue. If you drink alcohol, you're more likely to have heartburn, and also smoking. The last thing is your weight. If you're a little obese, you're overweight because the pressure in your abdomen is a little higher, so you're more likely to have heartburn. And I probably, a lot of women out there probably know when you're pregnant, you get heartburn and people tell you that, hey, your baby's don't have a lot of hair. Yes, because when you're pregnant, you carry a lot of weight in your belly, also the baby is pushing up, you're gonna more likely to have the heartburn symptom during the pregnancy.
But what about the hair?
How about the hair? I had heartburn in my third trimester. My baby didn't have that much of hair though.
Okay, so maybe that part's not true. So diet sounds like is very important, and presence of a hiatal hernia sets you up for having GERD. So why does GERD matter? Why do we need to treat it? Is it just heartburn, or are there other things that you can have that are problems associated with that?
So what does heartburn mean to you, if you think about it? When we talk about heartburn, we have this burning sensation, not just burning, sometimes you feel very tight, sometimes it's just a pain, and sometimes it goes through your neck and goes through your shoulder, almost feel like a heart attack. So we do have some patients that keep having chest pain, going to the ER and cardiology, and at the end we realize actually the heartburn causing the symptom. That's the number one symptom of GERD, but what else is in there? Sometimes we see patient has lots of coughing or asthma, trouble breathing, what we call reactive airway disease, and they have this chronic cough. They get referred to the ENT doctor and did a scope, realize that, hey, all the things that your stomach is reflexing back up doesn't stop just right here. They go to the back of your throat, and you can go the wrong way, go through your windpipe. That's why some patients come in with more a chronic cough, more a burning sensation, even up here, even the voice will change because of chronic burning with the acid. There's also a subset of patient come in because they're having difficulty eating. What it does is that when they eat, they feel like, hey, I feel something stuck right here, and it takes a while to go down. Or every time they eat, just like, hey, even here in the neck, they feel something stuck in there. It has difficulty eating. And we actually do evaluation with endoscopy. What we found out is there is what we call a stricture, which is a narrow end of that tube. So your food goes down and hangs right there. And what happened was because the acid keeps refluxing back up, and your body gets inflamed and it gets scarred down, actually more like a scar tissue. It fixed right there. So you start having difficulty eating, feel like your food is actually stuck right here. And I also have a lot of patients who tell me that when they sleep, sometimes not even when they sleep, which is chilling and whatnot, they feel there's food and acid, bitter taste going all the way up to their throat. That's one of the symptoms too, and that patient who had like sleep on 2 pillows because when they lay down, just go all the way and they won't be able to sleep. All this, other than just chest discomfort, heartburn feeling, they are all associated with the heartburn and GERD.
So you can actually have real damage to your esophagus, and you can have damage to your airway, and even pneumonia. We have patients who show up sometimes with recurrent pneumonia. They're constantly getting admitted to the hospital with pneumonia, and then find out down the road that it's actually because they're having reflux of acid and stomach contents.
That's right.
So who needs to be tested for GERD? It's very common. I know a lot of times now, because we have these good medicines, some people don't even get tested. They just get put on medicines, and if your symptoms get better, we tell you you have GERD. But how do you decide who needs one of these endoscopy procedures or other testing for GERD?
So usually what happens when you started having some heartburn and whatnot, you started to, technically you should go to your provider and talk to them about it. But over-the-counter medicine is so prevalent right now. People just go to Walmart and whatnot and buy their own medicine and just kind of, I'm better, I'm going to forget about it. But I would recommend if you have a heartburn symptom, the GERD symptoms, always talk to your provider. And most of the medication actually are for the acid reflux. They're not actually meant to be long-term. So if you keep having problem, even just like one round of medicine, you really should talk to your doctor about getting evaluated for a true diagnosis of your GERD. Because you can come to a doctor and you say, hey, I have heartburn more than twice a week and I qualify for the diagnosis of heartburn and you GERD, then you got put on medication. But what you need to do is actually talk to your doctor about maybe a referral to a GI doctor, maybe an X-ray to evaluate for it, or different studies. So to truly diagnose GERD and associate for and evaluate for all the damages that it actually will cause in your esophagus is number one, endoscopy. It's called an EGD, which we do, all the GI doctor here do, and pretty much all the surgeons here do What it does is you actually use the camera to look at your entire GI tract, the upper part of it. Tells me if you have inflammation in the esophagus, any scarring in the esophagus, any problem in your stomach. It's just an overall evaluation of your upper GI tract. That's very useful for diagnose Barrett's esophagus. We'll get to that later. And also we talked about the narrowing, that you cannot swallow very well. That EGD potentially can treat it at the same time. That's the number one diagnostic test you will need for GERD. The second thing is, if there's no GI available and whatnot, or as a combined study, we send you to a swallow study called upper GI. So what it does is that you drink some contrast and they take x-ray, boom, 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 in real time. So they see things going down here. Does it go back up? Does it just roll around here, trouble going down? It gives an idea how you clear the acid, if the acid actually goes back up. There's other study that would look for specifically the pressure in your esophagus and the pH acidity in your esophagus. It's performed not as commonly, but it's a very valuable test for diagnosing GERD and also associated issues with it.
So what about once you diagnose GERD, if we have medicines that treat it, is that enough? Do you just go on medicines, or how do you actually treat the GERD once you find it?
Well, before that, you're gonna be committed to change your lifestyle a little bit. You gotta quit smoking, you gotta avoid alcohol, because otherwise, if on your own you're not trying to help yourself, we can't really do everything for you. Of course, we talk about the caffeine. You can cut down. I'm not saying that completely no. The tomato things, and I was just thinking that pizza is perfect. You have garlic, you have tomato sauce, you have greasy stuffed cheese. It's like set up for heartburn.
Yeah, that's probably the number one thing that people tell me
with pepperoni on the
that
top.
makes their heartburn worse is pizza. It's kind of the perfect storm.
Right.
The perfect heartburn storm.
Yes. And if with this really doesn't improve with the just lifestyle changes, you go to your provider. Usually what happens, there are two types of medication that we use for stomach acid. One's called a H2 blocker. You could probably see it over the counter like Pepcid, Syntac, that kind of basic stuff. It's called H2 blocker. They are working pretty well. They're not as strong as the PPI, but a lot of time they actually do the job with technically a little less side effect. That's the first one. One of the choice you could have. The second one is called proton pump inhibitor, the PPIs. So you probably heard about this, like the Prilosec, the Nexium, the purple Nexium, I don't know, Dexilan, Esophagus, what else, I'm not sure.
There's a lot of them.
Yeah, a lot of them, right? This is like most common thing that we use to treat GERD, but actually most of those medications are actually approved for only short-term use. They're not for you to use for years, 20 years, 30 years. So ideally, if you're getting better and we get off the medication, you're good, that's fine. But if you're having issues, even with medication, you should talk to a surgeon about it, because it usually will end up evaluating you for maybe you have a hiatal hernia, which is a fixable issue. And a lot of times to reinforce the lower esophageal sphincter, we do a hiatal hernia repair on the top, we do a fundoplication of the stomach together, like double control for your reflux. That's one of the thing that we do. Some of the surgeons do in this town to fix reflux, which actually helps a lot of people, especially for the patients that they just have simple heartburn. They have reflux, they have cough, they had the bitter taste in their mouth every night, they couldn't sleep. That actually surgery helped them a lot, because the medication could stop the burning sensation, but it does not stop the refluxing process. Things still coming up, you just don't feel it. It could still cause damage to the esophagus, just not the acid and other content. So surgery is also an option if you're really suffering from GERD and heartburn and not getting better on medication, or you just want to get rid of it, the reflux part of it.
Yeah, so how do you decide who is a candidate for reflux surgery?
Usually if you're what we call medically refractory GERD, means you're on medication, your heartburn doesn't get control, you just can't really breathe well in the middle of the night because of all the reflux, I would say that would be indication to come to surgery.
So people who still have symptoms even if they're on medications.
Correct.
Other things I think that we see are people who have regurgitation of a lot of food. If you can neutralize the acid with medicines, but if you still have a lot of food coming up, sometimes the reflux surgery will help with that. Or people who have signs of chronic damage to their esophagus, even with the medicines, are sometimes good candidates. Or some people come to us and say, I have good control of my reflux with medicines, but I just don't like the idea of taking a medicine for a long period of time.
Sometimes we'll have patients that you wouldn't believe it. We'll have patients who's been on the PPI since in their early 20s. They need to get to us until in their 40s. They've been taking the medicine for 20 years. And all the medication, every single medication has its own side effect. Nobody wants to have more and more medication. So if you feel like, hey, medication, fine, I have no symptoms, but I really don't want to take this anymore, I guess surgery is actually be a good option, because we able to get you off of the medication after the surgery, unless you already have certain disease, a Barrett's esophagus needs surveillance on that.
Yeah, so we mentioned at the beginning that we're talking about this now because it's Esophageal Cancer Awareness Month. So what's the link between reflux and esophageal cancer? Does everyone with reflux get it, or how does that progress?
So we're actually getting into what could happen with GERD if it's untreated, and what's the associated complication with this. Yeah. Like we talked about Barrett's esophagus. If you imagine your esophagus, it's not really, the cells in there is not really designed to tolerate all this acid coming back out, getting inflamed and all that. So eventually they start to change their characteristic into a different type of cell that actually will tolerate the acid a little more, but act really different compared to the normal cells in the esophagus. And that happened, it's called the Barrett's esophagus. Now, about 10% of the patient with GERD will have Barrett's esophagus, and only one out of 20 of those patients will actually have proper diagnosis and know that you have Barrett's esophagus. Now, what's so important? Barrett's esophagus is actually associated with a cancer. So if you think about it, general public out there, there is a 1 in 500 chance you could have esophageal cancer. But if you have Barrett's esophagus, which is strongly associated with reflux and heartburn, you are in 1 in 20 chance. Think about that. So 20 people on the street with heartburn and actually with Barrett's esophagus, one of them is going to eventually go into having esophageal cancer, and not all of them even know about it. So that's why Barrett's esophagus is so important, and as a complication associated with GERD and heartburn. That's why, as us, we're trying to tell you that, hey, if you've been on the medication for a long time, or you probably should be evaluated by endoscopy, because that's the way to tell if you have Barrett's esophagus. Once we know if you have it, we're going to have to continue surveillance, means that you're going to have the EGD pretty much every year. We'll biopsy you, make sure there's no cancer in there. If there's any more aggressive change in there, there's a treatment we can do early instead of actually going for surgery. Treatment endoscopically to actually get rid of those cells that's trying to change into cancer. But if you don't know, there's no way to treat it.
Right.
Right. So that's why the GERD is not just a little bit discomfort, It's actually something that's a disease, actually can have consequences like that. In terms of esophageal cancer, there's mainly 2 types, but the type that's in the Western countries is the adenocarcinoma of the esophagus. And we see this more because actually it's associated with heartburn and Barrett's esophagus. And esophageal cancer generally has a very poor prognosis, mainly also because we don't get to diagnosis until it's quite late. And we always talk about the 5-year survival stage and things like that. And there's less than 1 in 5 chance to survive 5 years after diagnosis of esophageal cancer. So it is really, really poor prognosis. It's all about being aware of this. Like this month we're talking about esophageal cancer, and the most prevalent cancer in the Western country actually are associated with heartburn and GERD. So that's one of the most important thing here today when we're talking about the heartburn and the GERD. Not just the symptom, not just this thing, not just the reflux, but also the awareness of the esophageal cancer and Barrett's esophagus.
Yeah, and if you have heartburn or GERD, and even if your symptoms are controlled, if you've been on medications for a long period of time, you can still have chronic damage to your esophagus. And so even if your symptoms are under control, it's still important at some point to get checked. And the best way to do that is to see your primary care doctor or see a gastroenterologist. You can come see us as well, but get checked and see if you have that damage or that Barrett's esophagus.
Some of the other things also associated with heartburn and GERD that we talked about a little bit was a hiatal hernia. When we talk about hiatal hernia, I was talking about, hey, a little dilate a little bit, but what happens is when you have a big hiatal hernia, your stomach kind of push all the way up in your chest. If you imagine your stomach is actually a water balloon. So when it goes up, it gets pinched in the middle, so I have a little pouch on the top, little pouch at the bottom. And your food can get stuck in the top pouch and you can have nausea, vomiting with it. And when you start having that for a long time, even reflux, you start getting to aspiration pneumonia. What that means is that things go up, went through the wrong way, went down the windpipe, get you a pneumonia. So sometimes we'll see people, like you said, coming in just recurring on and off, keep pneumonia, what's going on? You get a CT scan, the stomach's all the way up here. And this is something that we see, sometimes very devastating because we see older patients coming in and they're not already like a 20-year-old super and deal with pneumonia, okay. They might come in with other things, and when they had the aspiration pneumonia, a lot of times the last straw for them. And we didn't get to fix them, and by that time they just had a pneumonia and we didn't ever get a chance to fix them. We've seen several of those. Over the years, actually quite a bit. So it's one of the things that could be evaluated with endoscopy too. Also the upper GI swallow study will show you too, but the endoscopy pretty much across the board is what you need for a proper evaluation of your GERD. The next thing is, it happens sometimes, but nowadays not as often because you have medication. You can have a GI bleed. What it means that you are bleeding your GI tract. We've seen esophagus actually bleed when the esophagitis was so bad, they start having ulcers in there, linear ulcers, and they start bleeding. And people coming with nausea, vomiting, obviously, because it just so swollen, everything's shut. And also they have anemia because of that. So we really need to pay attention to that, and just not medication. Like we'll go back to the endoscopy again, because once that one thing gets you a lot of information associated with the GERD. The very last thing is, we talk about medications, we'll talk about a little bit of side effect. The proton pump inhibitor, the PPIs that we talked about, the Nexium and Protonics, has some studies coming out about their side effect. I know it's kind of controversial because we don't really have a large research study randomized about it really this are true or not. But I would say probably at least it's been around about 7 years. Some study came out about association with fractures in the wrist and spine. There's some association with certain cancer, association with kidney disease, association with I don't know, all that side effect. So I actually have started seeing some primary care doctor a little hesitant of putting you patient on PPI for a long time, and they actually will switch them to either H2 blocker like a Pepsi and things like that, or actually talk to us about surgery. I'm not saying that PPI is bad for you. I'm just saying that some research, not large research, suggesting some side effects. So like we talked about, who wants to take medicine forever? We want to take one last at a time.
Yeah, and these are talking about patients who are on them for 20, 30, 40 years.
That's right. We have patients like that. I have a patient who's been on that since 18. You're like, wow, you've been on medication for 15, 20 years before you got to me. And you're like, amazing. Like, but sometimes they're lucky and there's not much damage. Not as obvious damage to their esophagus. Some of them are just like came in straight with Barrett's esophagus.
Yeah.
So I guess overall here, I don't know if you have anything to add in terms of the things we discussed.
Yeah, I think the take-home point is that heartburn and gastroesophageal reflux disease, or GERD, It's very, very common. It's very, very treatable. But if it's not treated and you don't address it, you can actually develop some serious problems. And it's important, first, if you're dealing with this, to actually see your doctor and get a true diagnosis. And if it doesn't go away with adjusting your diet or a short course of antacid medications, then you really need to get checked and be screened, usually with a scope of your esophagus and your stomach, to try to prevent these other problems, these pneumonias, these large hiatal hernias, and even esophageal cancer.
That's right. Don't think it's just some kind of discomfort. Don't think it's just like, hey, I can deal with it. It's just one of the things that if you start having symptoms more often, you really should talk to your provider about getting it checked out.
And it's very simple. You don't have to take a prep for an EGD. That's what
Yes.
people usually hate about a colonoscopy.
It's not a colonoscopy, no.
You don't have to take a prep. You come in. It's usually a same-day procedure. It's very simple. There's a lot of people in town who can do it. So make sure you get checked out. And
all right. Well, thanks for having us here. Talk to your medical doctor and get a referral to your GI doctor or us, and then we can figure it out for you. All right?